Sup, chooms, how y'all living? Hope everything is Nova and you all had a blessed Memorial Day. So if you guys have followed my channel, then you know I'm a big fan of what's called evidence-based medicine. Now, that term gets thrown around by a lot of pseudo-intellectuals these days, as well as bro-scientists, but what it is just medicine based on science. And when I say science, what I'm talking about are high-quality studies like randomized controlled studies and not anecdotes like case reports or posts you see on hair loss forums and subreddits. That's why I recommend conventional treatments like Finasteride and topical minoxidil for hair loss, because their effectiveness and safety have been proven in dozens of studies involving thousands of subjects, and that's why I don't recommend things like onion juice, broccoli, scalp massages, or abandoned research chemicals tested only on rodents whose effectiveness is based on very low quality research or just testimonials you read on the forums. So recently, some people have proposed the next step in medicine that goes beyond evidence-based medicine is something called PM, which depending on who you read means either personalized medicine or precision medicine. What PM is medicine that is customized to each individual's specific characteristics, because everyone is different after all, and so a treatment that works on one person might not work on a different person. I kind of thought this is what most doctors do anyways when they see a patient. They try to individualize care, which is what's called the art of medicine. But this precision medicine or personalized medicine concept really took off with the advances in DNA technology. Today, it's possible to take a swab of your mouth and send it off to a company like 23andMe and get your genetics analyzed, which tells you about your ancestry and about diseases that you might carry. Now, we know that androgenic alopecia is a genetic disease which involves over 250 genes. So one has to ask, would genetic testing be useful in predicting if you are going to get androgenic alopecia? And would it be useful in deciding the best way in how to treat your specific case of androgenic alopecia? Well, none other than one of the major members of the Haircafe cinematic universe, Dr. Ralph Trueb, has weighed in on precision medicine and how it applies to hair loss in this article. In the article, he looks at how precision medicine might be applied to different types of hair loss, including alopecia areata and some rare forms of scarring alopecia. But he also looks at what we're most concerned about on this channel, and that is the curse of androgenic alopecia. He quotes a study that looked at whether the genetics of the androgen receptor would predict responsiveness to finasteride. In this study, the investigators looked at the DNA of the androgen receptor in 488 men with androgenic alopecia. The investigators found that there was an area of the androgen receptor DNA that had some repeating sequences, and there was a rough correlation between the number of these repeats and the amount of improvement with finasteride. So, in other words, the DNA test could predict how well you'd respond to finasteride. The other type of genetic testing for androgenic alopecia that Dr. Trueb brings up is looking at genetic patterns that predict whether or not someone is going to get androgenic alopecia. In this study, the investigators looked at 20 different genetic variations and found that the more of these variants you had, the more likely you were going to have androgenic alopecia, as you can see in this figure here. Well, that's not surprising, because like I already said, there are over 250 genes that determine the trait of androgenic alopecia, and I'm sure that with more research, it will become possible to pretty much predict completely accurately whether or not you're going to inherit the slaphead curse from your parents or not. But right now, we don't really have that kind of practical testing, so it's probably most prudent to just assume you do have the androgenic alopecia gene and get on finasteride as soon as you possibly can. Especially since finasteride doesn't always reverse lost ground, so you don't want to be in a situation where you'll require a hair transplant. Dr. Trueb also brings up testing for sulfotransferase levels in plucked hair follicles in order to predict the response rate to minoxidil. You see, there are some people where topical minoxidil doesn't work very well, and these people have a deficiency of the enzyme sulfotransferase that converts minoxidil into minoxidil sulfate, which is the active form of the drug. It turns out that if you do have a deficiency of sulfotransferase, you can add tretinoin to your regimen, which upregulates sulfotransferase, and I did a video on this which I'll link below. So Dr. Trua brings up some other complicating factors that can worsen hair loss in people with androgenic alopecia, and this includes things like seborrheic dermatitis or hypothyroidism or polycystic ovarian syndrome in women, but these aren't really relevant to genetic testing, and genetic testing is what we're interested in examining today. And this brings us to the latest craze in the hair loss community known as Trichotest. So what is Trichotest? Well, it's kind of like 23andMe, but it's specifically for hair loss. The way you use it is that you do a swab of your mouth and then send it off to Genomics along with a few $100 US, though it's hard to find online exactly how much the test really costs. One site from England listed the cost as £295, so I would guess it costs more than $300 US when you factor in things like the exchange rate between British pounds and US dollars. So what does Trichotest test for? Well, one thing it doesn't test for is whether or not you have the genetics to develop androgenic alopecia, which is a bit of a disappointment, as it would be nice if a practical test like this could exist. Also, the test doesn't look at the androgen receptor, which, as I showed in the study that Dr. Trua mentions, may have some predictive value in predicting the effectiveness of finasteride. What the Trichotest does is that it looks at 16 different genes, a few of which are relevant to androgenic alopecia, but also a bunch of them really don't have anything at all to do with androgenic alopecia. Here are the genes that Trichotest does test for, though. Well, the genes in the first column are pretty indecipherable, but the second column shows what these genes actually affect. For example, what the hell is GPR44? Well, it's a gene that encodes the receptor for the prostaglandin PGD2. Now, prostaglandins, what they are, they're chemical messengers that are similar to hormones, only they act locally. Prostaglandin levels can affect the hair growth cycle by either stimulating hair growth or by inhibiting it. Some of the bad effects of DHT in people with androgenic alopecia may in part be mediated by prostaglandins. So prostaglandins may be involved in the so-called downstream effects of DHT on the hair. So prostaglandins and DHT are directly related to DHT causing changes in prostaglandin levels that end up damaging the hair. So despite the role prostaglandins play in the hair growth cycle, prostaglandin modulating treatments have nevertheless, unfortunately, not proven to be effective in treating androgenic alopecia, and I made a video on prostaglandins, which I'll link below if you want to know more about that specific topic. So getting back on subject, let's take a look at this GPR44 gene, which is a gene that creates the prostaglandin PGD2 receptor. It turns out PGD2 is one of the prostaglandins that actually worsens hair loss, and high DHT levels increase PGD2 levels. Trichotest looks for two variants of this gene that are present in 19 and 34% of the population respectively. These genetic variants end up increasing the number of PGD2 receptors or enhance the stability of PGD2 receptors. So theoretically, if you have either of these mutations, you might have more PGD2 effect on your scalp and worse hair loss. So that's all fine and dandy to know, but what can you do with this information Trichotest gives you? Well, the third column of the table suggests you take something called prostaquinon, which has a trademark symbol after it. So to quote the Fagron website, quote, "Prostaquinon trademark is a Fagron phytocomplex derived from the essential oils of Nigella sativa seeds," unquote. So if this test for GPR44 comes back positive, Fagron wants you to take its own supplement, prostaquinon, because, quote, "As prostaquinon trademark acts on the inhibition of PGD2 synthesis, the results obtained with Trichotest trademark provide an indication about the dosage and potential efficacy of treatment with prostaquinon trademark," unquote. So the most obvious thing to note here is that Fagron is trying to sell their own supplement based on the results of the Trichotest, which seems pretty shady. This is not true of everything they test, but it is true of some of the genes that they are testing for. So seems pretty convenient to me that they just happen to sell a supplement to treat an outcome only their own test can predict for. In two cases, they recommend their own hair loss supplements based on the results of Trichotest. We already saw they recommended prostaquinon for abnormalities in the PGD2 receptors, but they also test for a single variant of the IGFR1 gene that affects the activity of the IGF-1 receptor. So IGF-1 is another hair growth stimulating factor that is influenced by DHT, and if the receptor has the abnormal variant, Fagron recommends another of their supplements called I-Grantine F1 trademark, which supposedly increases IGF-1 levels. Now, I looked into this I-Grantine F1 stuff, and it contains a substance called cefarenthine that supposedly increases IGF-1 levels. However, it looks like this cefarenthine has only a minimal effect on hair growth. This study looked at applying cefarenthine to the scalp of 23 men and found a slight acceleration of hair growth from 0.243 to 0.281 millimeters per day, but changes in hair density and hair thickness were not statistically significant, so these effects really are no better than what is typically seen with placebo treatments. So this is yet another hair loss supplement that might have a minimal effect, but is it at all necessary when we already have much more effective treatments on the market like finasteride and minoxidil? Furthermore, even though IGF-1 plays an important role in the angiogenesis of the hair follicle's microvascular structure, IGF-1 supplementation has not been shown to help stop androgenic alopecia, with the sole exception of being people who have Laron syndrome, which is a condition where people have a genetic mutation that causes them to produce very low levels of IGF-1, and I did a video about that which I'll link below. Anyways, the point is that if you take the Trichotest, one of the possible results is that Fagron will recommend that you should buy one of its supplements, so a little bit of a conflict of interest there. But what about the other genes that are tested for in Trichotest? Well, they test for two other prostaglandins, PGF2 alpha and PGE2, which are hair growth stimulants, and say that the results of the testing might affect how effective latanoprost or minoxidil are. Now, latanoprost, what it is, it's an analog of PGF2 alpha, but it has not been shown to help with androgenic alopecia, and latanoprost is one of the compounds I mentioned in my video about prostaglandin treatments, which is linked below. So what about the other prostaglandin gene we just mentioned, PGE2? Well, the Fagron website mentions that one of the proposed effects of minoxidil is to stimulate PGE2, but that's probably not minoxidil's major mechanism of action, and in fact, no one knows for sure how minoxidil works, but the main theory of how it works has to do with its effects on potassium channels and not on its effects on prostaglandins like PGE2. So it's not been established whether PGE2 levels would do anything to affect how well minoxidil works. So once again, this seems like a pretty useless test. It's like the test is trying to find problems that don't really even exist and that wouldn't affect how you would treat your androgenic alopecia anyways. Then there are a number of tests that really have no conceivable relevance to androgenic alopecia at all. They test for the GR alpha gene, which affects how people respond to cortisone therapy, and cortisone isn't used for androgenic alopecia, so this gene is only relevant if you have alopecia areata, which is a much rarer form of hair loss, which is an autoimmune disease and is often treated with cortisone injections. But if you have androgenic alopecia, this test is of course completely irrelevant. That's also true for many of the other tests, like for example, they have tests that test for genes that affect vitamin A, biotin, and collagen synthesis. Now, theoretically, severe vitamin deficiencies can cause hair loss, but deficiencies that are severe enough to cause hair loss are extremely rare in the industrialized world. The Fagron site provides no evidence that the mutations they test for regarding these vitamins have any effect on hair loss or that taking vitamin supplements will improve your hair, but that's what they recommend anyways. On the other hand, you can just take a daily multivitamin and not have to worry about any of this, so I really don't see the point. The test also looks at the gene for what is known as angiotensin converting enzyme, also known as ACE. This is an enzyme that may be relevant if you are taking ACE inhibitor drugs for high blood pressure, but here, Fagron tries to tie it into hair loss by saying that it has to do with the Bloodflow theory, which I have discredited in many previous videos, and I'll link some of them below. So, the ACE enzyme is an enzyme that regulates blood pressure, but blood pressure has nothing to do with hair growth. There are people with high blood pressure that have full heads of hair, and conversely, people who have perfectly normal cardiovascular health who are completely bald. The blood flow to the scalp is not inhibited in bald men, and low blood flow in bald scalps is in fact a consequence of hair loss and not a cause, since what DHT does is it destroys the microvascular structure of the hair follicles. We also know that blood pressure medications, including ACE inhibitors, do not affect hair growth, with the only exception being minoxidil, but minoxidil's effect on hair growth has nothing to do with its effects on blood pressure, otherwise other blood pressure medications would also work to stop hair loss. So the testing for the ACE gene really has no relevance to androgenic alopecia at all. And I think they're just throwing this test in because a lot of people erroneously believe in the Bloodflow theory, but like I have mentioned many times before, I have completely debunked this theory in several videos, and you can check them out below in the description if you haven't seen them yet. So that leaves us with 3 tests that might be relevant to androgenic alopecia. The first one tests for the gene that codes the sulfotransferase enzyme that transforms minoxidil into the active ingredient minoxidil sulfate. Trichotest tests for a variant that is present in 22% of the population that results in low sulfotransferase levels. So finally, we have a test that might be helpful in predicting if you will respond to minoxidil, though you can also test the levels of sulfotransferase in plucked hairs using what's called a minoxidil, which you can actually do from the comfort of your own home. The minoxidil looks at the actual sulfotransferase levels in your hair follicles as opposed to looking just at the sulfotransferase gene, which is what the Trichotest does. Remember, the Trichotest just looks at one genetic variant of the sulfotransferase gene that could cause low sulfotransferase levels, but there are probably other genes involved too, and what you really want to know is what the sulfotransferase levels are in the scalp, since that is where minoxidil is applied. So testing the levels directly is a much better test rather than just testing for this one specific gene variant using the Trichotest. In any case, I don't think you really need to test for this at all. If you suspect you are a non-responder to topical minoxidil, you can just add tretinoin, which upregulates the sulfotransferase enzyme. So I'm not sure this sulfotransferase gene test justifies all the other useless tests that are included in the Trichotest, especially since there are already better tests out there to test for the sulfotransferase enzyme, such as the minoxidil I mentioned earlier. Finally, Trichotest tests for variants that affect the activity of the 5-alpha reductase type 1 and type 2 enzymes that convert testosterone into the trash hormone DHT. It also tests for the activity of the aromatase enzyme that converts testosterone into estrogen. So finally, we have something that might be relevant to androgenic alopecia. The test looks at 2 variants of the 5AR genes, one which causes higher 5AR type 1 activity and one that causes lower 5AR type 2 activity. So what happens if you have these variants? Well, the type 2 isoenzyme is the one that is most responsible for elevated DHT in the hair follicles that causes hair loss, whereas the type 1 isoenzyme is more important in the sebaceous glands, resulting in separate problems like acne. So variants in the type 1 isoenzyme may not have any significance for hair loss, and in fact, it isn't known to play any role in hair loss at all. Also, a variant that decreases type 2 activity might actually be helpful for hair loss because that is essentially what finasteride and dutasteride both do. They block the type 2 isoenzyme, which lowers DHT levels on the scalp. Now, dutasteride also blocks the type 1 enzyme, whereas finasteride doesn't, at least not to any significant amount. So Fagron is saying that if through your genetics you have a high 5AR type 1 activity level, then maybe dutasteride should be used instead of finasteride. However, the main reason dutasteride is more effective than finasteride is that it is more powerful in blocking the type 2 enzyme than finasteride is. It really has nothing at all to do with its effects on the type 1 isoenzyme, and that is a very common misconception that many people believe. So the information on the 5AR isoenzymes from Trichotest is not useful in selecting a treatment, since it makes an unproven assumption about the importance of the 2 5AR isoenzymes it tests for. And I think most dermatologists would still recommend starting with finasteride first and then only going to dutasteride if after a year later you're still losing ground on finasteride. Dutasteride at its standard dose of 0.5 milligrams per day is more powerful than finasteride at 1 milligram per day, and in cases of extreme hair loss, dutasteride can be safely titrated up to 2.5 milligrams per day, and I have a video where I talk about that, which I'll go ahead and link in the description below. So the last test is a test for variants of the aromatase gene, which is the gene that converts testosterone into estrogen, and the aromatase variants they test for result in decreased aromatase activity, which would mean less conversion of testosterone into estrogen. Theoretically, if you have less aromatase activity, you might have more testosterone to convert into DHT, which could progress your androgenic alopecia, but this isn't a problem if you're using a 5AR inhibitor, which of course you should be if you're serious about fighting hair loss. So this might be an interesting theory, but practically speaking, this test doesn't serve any purpose if you're already on a 5AR inhibitor. Testosterone, contrary to popular belief, does not cause hair loss, at least not by itself, and this is explained in my video on the subject that I'll link below. So again, I don't think this test is very useful. So What use is there in this Trichotest gimmick? Unfortunately, not much really. Some of the genetic testing is obviously just a marketing ploy to push these unproven fad-grown supplements. Also, a lot of the tests don't have anything to do with androgenic alopecia, which makes it worthless for 99% of hair loss sufferers. The only possible benefits are testing of the sulfotransferase enzyme, but as I already explained earlier, we have superior means of testing for that enzyme to begin with, and most of the time any issues with sulfotransferase can easily be mitigated by just incorporating tretinoin into your routine. Testing for the 5AR genes probably isn't all that useful either. Now, regardless of the outcomes of this test, you should probably start with Finasteride, and if you begin treatment early enough, that is probably all you'll ever have to use. If you really don't respond well to Finasteride after an adequate trial, say at least a year of usage, then that would be an indication that it might be time to switch to dutasteride. I certainly would not recommend starting off with dutasteride just based on an unproven genetic test though, especially since clinical trials already prove that Finasteride will work very well in the vast majority of people who use it. I didn't mention it before, but the Trichotest also includes a lifestyle questionnaire that has nothing to do with genetics. It asks about things like smoking and alcohol use, but you really don't need to take a Trichotest to know that smoking has many health detriments, including a possible negative effect on hair growth. The data on alcohol is a bit more conflicting, but certainly for your overall health, you probably want to abstain as much as possible, if not completely, from both smoking and alcohol use, and I have videos talking about their effects on hair loss below. Certainly, nobody needs a Trichotest to know that smoking and alcohol are bad for your health. So, I do appreciate what Trichotest is trying to do here, but unfortunately, I think they're muddying the waters with this test, which really doesn't do anything but make fighting hair loss seem more complicated than it really is. It's really not going to be helpful in telling you whether or not you're going to have androgenic alopecia, and it tests for far too many factors that are completely irrelevant to androgenic alopecia, like nutrition and Bloodflow. That's the kind of shit snake oil salesmen like to promote, since they want you to believe there's more to androgenic alopecia than just lowering the trash hormone DHT. But the truth is, that really is all there is to it. There are, of course, a huge cascade of biochemical factors involved in the process of androgenic alopecia, but the linchpin here is DHT. You take out the DHT, you take out the mothership and save the day. So don't get bogged down in all the details and just focus on the obvious here. Your hair is being killed by DHT because you are genetically prone to it. The way you stop it is to lower your DHT. You can further enhance hair growth by adding compounds like minoxidil, but ultimately, the way you treat androgenic alopecia is by going after the androgenic compound progressing your hair loss, which of course is the trash hormone DHT. No need to act like a neckbeard to pretend it's deeper than that. Sometimes a cigar is just a cigar, and a trash hormone is just a trash hormone. And with that, I'll see you next time, my fellow hair loss witchers. Take care.